we are.
Okay, we are. And are we connected to Kelowna also?
It's,
Has that ever happened?
they'll connect in to our YouTube site.
They'll connect to our YouTube site?
Yeah.
Okay, great. All right. So shall we be generous with 1 minute? 1 more minute to start?
Sure. That's fine. I can get another computer if we need to. No, actually, it should be fine. Just go over there later just to check.
So good afternoon, everyone. Thanks for coming. Welcome. Let me begin by acknowledging that it's our privilege to meet on the traditional, ancestral, and unceded territories of the Musqueam people. We're grateful for that opportunity. Welcome to the second of our Voices in Health seminar series here at SPPH. The plan for this year is to have these series monthly, and we're alternating between topics, I would say, of more local and national importance, and topics of more global importance, although sometimes it's hard to draw that line. For example, in our first of these series, we learned about legal efforts to take action in Canada and in the United States to mobilize government to address issues of climate change. This is clearly local and national, but also global. So hard to know. Maybe we'll learn something this year about how or how not to draw that line. Anyway, this is the second in our series, and the focus today is more on global health. And I just want to announce that we are expecting the next in this series to take place on November 18th, so stay tuned for more news on what we'll be doing. And we look forward to a year of engaging you all together in these discussions with us. We're also pleased to note that this seminar will be available online, and we will be providing you more information, and those of you who are online, on how to contribute your ideas and questions as we go forward. So with that brief introduction, Professor Craig Mitten, Associate Director for Research in SPPH, has kindly agreed to be our moderator today. Craig, you're on.
It's an easy crowd. You get applause for that.
Really?
So welcome everyone. It's great to have a great room of people, and I know we're also live streaming up to UBCO, to the Institute for Healthy Living and Chronic Disease Prevention. So thank you for folks in Kelowna who are in, and also anyone else here in Vancouver across the campus. So thank you all for being here. So the plan is we are going to have Stefan give us a keynote, which will last 45-50 minutes. We're then going to have a quick break. We appreciate it's at the end of the day, and if people need to sneak out for childcare or other reasons, that's your opportunity. And then we are going to have a panel session with two esteemed members from UBC Vancouver, giving a few comments in response to what they've heard from Stefan. And then we're going to do a moderated panel session whereby we'll invite questions and input from the audience, both to our panelists as well as our keynote. And ask that if you have any questions that you hold off, we are going to have all the questions after Stefan has given his keynote, and we're going to do that completely online with Slido, and we'll put the details up after Stefan's presentation for how to log in on your phone and pose the questions, and then we will be able to moderate those questions as we go. So without further ado, I'm going to hand it over to Stefan to give us your take on this critical issue of equity in global health, and just say welcome. You're here for a short visit.
A few more hours.
A few more hours. You're going out to
Well,
Africa
enjoyed a
tonight.
beautiful weekend.
But yeah, so it's great to have you here, and welcome, and over to you.
Thank you, Greg.
What you've got now.
So should I, yeah, maybe it's better with the microphone for here, but I think the other microphone for people online. So it's a pleasure to be here, and what I want to talk about today is work in global health priority setting, which also I think we had productive exchanges today about how it can be relevant for work in British Columbia, in the province of BC, and in particular focusing on the issue of equity. And so please feel free to interrupt me as you have questions along the way. And I know that there's going to be time for discussions afterwards, including with the panel, and we can take questions as we go as well. So what I want to talk about today, and the menu for a presentation, if you will, is a little bit of background, which for some of you might be a bit of a rehearsing of many things you've heard, about why this kinds of inclusion of equity in the way we do priority setting or cost effectiveness analysis is relevant in what I sort of call the post 2015 agenda and the universal health coverage discourse. Then talk about and introduce the methods that we developed to do such work, which we call extended cost effectiveness analysis, ECEA, and which really deals about including both the disaggregation, the health inequalities per socioeconomic status in the way we do economic evaluations, as well as thinking about the prevention of medical impoverishment. Then I'll try to illustrate this with a couple of streams of work we've been doing, which is very relevant, or ECA is very relevant for the kinds of problems related to sin taxes, tobacco, sugary taxes, where regressivity is always basically put forward as an argument against raising these taxes. And then more generally speaking, I think what's useful in the context of thinking about designing national benefits package, which is in many ways what many governments or publicly financed programs are trying to achieve. Okay? And then a few concluding remarks. So a little bit of background about, to set the scene. Who has not seen these two pictures? Raise your hands. Everybody has, good. That's what's expected. But so you all have heard about the discourse on poverty, especially as we move from MDGs to SDGs. The first of the Sustainable Development Goals is to end poverty in all its forms everywhere. SDG 3 within it many indicators, hundreds of indicators with sub-targets and so on. The summary sort of line of this SDG is about achieving universal coverage, including financial risk protection for all. The financial risk protection piece of it is being an obvious link to poverty. And then when, in fact, actually, at the early times when Jim Kim was president of the World Bank, if you would Google him on YouTube, a lot of his discourse was always about the dual objective of eradicating poverty, extreme poverty by 2030, as well as lifting the bottom, or the incomes of the bottom 40% of the population. Long story short, maybe it's something that happens every 15 years when there's these major goals, but there's been this sort of, at least in terms of framing indicators, this sort of semantic around poverty reduction. Yet, if you think about the kinds of practical actions, and if we take this goal seriously, and you'll see why I'm starting my presentation like this, we might want to think about the costs, or we might want to think about specific interventions, their costs, and then their effectiveness in terms of poverty reduction. And then we might then think about our investments in terms of what are the best buys in terms of poverty reduction. However, it's not been such, like we have cost effectiveness in health. This is not something that has been readily implemented into setting priorities across sectors by World Bank and other development agencies. Now, another question, who has not seen this cube? Good. I'll come back. So this is basically, what we call the WHO cube, another sort of global thinking, that's out there, whether we like it or not. And in the World Health Report 2010, led by David Evans, who was then leading the health systems financing group at the WHO, in the executive summary, trying to summarize with 3 dimensions, what are major dimensions to consider on the way to universal health coverage. Namely, obviously, what kind of services, what kind of coverage is provided, what kind of services to be provided, and then the important question about what is the size of the direct costs with that very, in my view, quite narrow health sector focus. What is the size of the direct costs, or what's the share that should be borne by individuals out of pocket, as opposed to the health sector. So that, has been, initially, and then there's been, other geometrical figures that people have come up with, sort of initial way of launching the thinking about UHE. Now, what's interesting is, and that's my next slide, is that, well, there's been, quite some consensus. In fact, Peter was very much involved in slightly different ways, but a lot of scholars, and the work that Peter did with the Getting Health Reform Right, which I believe, that there's been a new edition, was really thinking about, major dimensions of health system performance, the level and distribution of health, the level and the distribution of financial risk protection, and citizen satisfaction. And in some ways, of course there are different things here. This is the same consensus that these things matter. Now, what's interesting is that when this report came out, we were left actually with no discussion about budget constraints. In other words, if my country is here, what do I do next? With what kind of money? Of course, this is 3-dimensional, so there's many ways you can go with, the next, budget, resources available. But it is not clear which one you should prioritize. Do you go vertically, horizontally, blah, blah, blah. And of course, if you're a low-income country, a lower middle-income country, et cetera, you have different sets of diseases, epidemiology, and obviously financial resources. So one question, that this raised is then how you move efficiently on the WHO cube, depending on the point you are in the cube, and then, what kind of directions you want to take and so on, which obviously might depend, obviously, I live in a country across the border that has, different priorities than, Canada. Every country is different, and I work a lot in Ethiopia, and the Ethiopians have their own social value. But it's very much about the social contract that, the politicians or the government sets with the citizens. Now, one thing that we try to think of is that, specifically in the context of global health and nascent health systems, but I would argue that it's relevant for any kinds of systems, is just that the kinds of contexts are obviously different. Is what we need to do is maybe have less of a narrow focus on technical interventions and cost effectiveness analysis, and think about a couple of things. Well, first is having more health system focus, which will come in 2 ways. One is that really when you develop a health system or you think about resource allocations, beyond the technical intervention, you actually have delivery platforms. You have, a surgeon doesn't only do ear surgery, he does a whole bunch of things. You have immunization program, which basically delivers a whole bunch of things. And that is the way technical implementers as well as decision makers think about these things. Things that are perhaps more physical rather than technological. And that is extremely critical in terms of more nascent health system. The second thing is that obviously, and we were discussing about this today, is that policymakers and decisions are not made on pure cost effectiveness grounds. There are many other criteria that people and decision makers care about when they make their decisions. Obviously, that which is maybe not as studied as we would like, cost, financial implications, burden, which constitutes the two main features underlying cost effectiveness, but also, health inequalities and medical impoverishment. And so what we were thinking is that building on, consensus from scholars, international agencies that I was talking about, these are things that, would be relevant to think about including for, maximizing returns on investment in the way we do economic evaluations. Any questions? All right. So then the two basic, which I'm gonna, I'll set up a little bit of methods that we developed for that, and then I'll show about a couple of examples which I already mentioned. The questions that, and thinking back about, my first starting slides about poverty reduction and so on, is maybe the two policy questions that are, in front of us are how you reduce medical impoverishment, how you redress, health inequalities, and then with a budget constraint. In other words, efficiently or cost effective. That is, maybe what we want to think of. So now what we basically, so we call these, ECA methods, and basically it's an attempt to really try to do that. So the proposition and what the methods does, and there's more technical details in these papers, is, maybe think more about health policy assessments and trying to really incorporate these two dimensions about redressing health inequalities and improving financial risk protection per given budget constraint. So in many ways that means thinking about inequalities across population subgroups, obviously across different socioeconomic groups, wealth quintiles, but also from a planning purpose, there's used to think about district level, a country like Canada is federal, there's a lot of things that get done at the province level. In Ethiopia, where Peter and I are working, a lot of regional autonomy is being implemented. So this kinds of thing, and that also in the way some of these, it's also relevant in Canada. Some of the provinces compare amongst themselves, and then they also, try to see what they get from the federal government or not. So these are important things as well. It's not meant to be only for a socioeconomic group. And the second thing is to try to quantify the financial risk protection benefits of health interventions. In other words, how by not only perhaps having free health care, but preventive interventions where you prevent diseases happening downstream, how you prevent financial consequences that can be very substantial for households. And that's especially relevant in the context of low-middle income countries where there's still high reliance on out-of-pocket spending. Now, I would also argue that my understanding is that Canada is basically discussing, what drugs could be made free at the point of care through what you call pharmacare. So the same thinking could be applied about what are these drugs that would prevent, or treat certain conditions and financial consequences related to that you want to prioritize. So that's basic. You have a basic idea, and the rest, in some ways, is more, mathematical only. The idea really is you take an intervention, just to rehearse what I said. So think about, and I'll talk a bit more about this afterwards, a package of vaccines, and then we're looking more or less at three bundles of things. First is the health gains, so it's vaccines for kids, childhood death averted, okay? And then the idea is to take a sort of household perspective, which to think, for instance, in the case of vaccine, which is a preventive intervention, then you prevent, say, severe diarrhea, rotavirus diarrhea, then you prevent the financial consequences of the out-of-pocket payments. I would argue also the fact that the parents have to take the child, maybe for a severe hospitalization, in 4 or 5 days. I mean, these can be very substantial, time losses and so on. And then trying to, compare that with people's ability to pay and to get a sense of financial risk protection. The last step is really to take into account the fact that if you have bills of $100 and you have a salary of $200, you're going to be much more impacted than if you had a salary of $1 million. Okay, and then trying to get a systematic, disaggregation by subgroup of interest, like socioeconomic status that are here. So let's talk about a couple of examples where this ECA could be particular. And what I'm going to talk about here is very different. In fact, actually, things that in terms of implementation would fall under different ministries often. One is how that could be useful, and I'll talk about some experience we had with working with, in particular with the Ministry of Health and Finance in Colombia. How that can be useful for, and I'll define that, to challenge the so-called regressivity of the doctrine, I would say, of seeing taxes. And then how, in fact, and this is natural extension of cost-effectiveness analysis and health technology assessment, this could be helpful for priority setting and then thinking about, designing national benefits package. So the first thing is, we'll discuss, the regressivity of sin taxes, and I'll take the example of tobacco taxes. Well, the first thing I want to show is that tobacco tax really works. Many would argue, that this is the single most, effective, tobacco control policy. Of course, you might want to combine them with smoke-free zones, things like that, but this is very effective. And this is an example, and the same graph exists also for a few countries like South Africa, where in France, for instance, you have the price of a cigarette corrected for inflation, and then the sales of cigarettes. And you see this beautiful dose response, which you don't always see in public health. So that really works. What does work, by the way, is not increasing a little bit, because obviously you cope, is you increase very substantially. And as I said, South Africa also went to a very substantial increase in taxes, tobacco taxes, early 2000s, and also had some people study that. And actually France, a couple of years ago, passed a significant increase that's also led to a decrease. And you can also, but I won't comment on this, you can tie the increases to different presidents and governments in France here. Anyhow, so that works. Now, what has been really, however, there's many countries in the world where these are, vastly underused, especially, countries with large populations of smokers like you have in Asia, Southeast Asia, like I mentioned, China, Indonesia, and so on. Now, one major political issue, which is always put forward, is that it's often regarded as regressive, and that means that compared to your income, if you're poor, you spend a more significant amount of cigarette expenditures than richer incomes. So, and by the way, the same kinds of things. By the way, that was the same thing with gasoline taxes. That's the same thing with cigarette taxes. Same thing with alcohol taxes, even though this one is maybe harder to implement, and so on. And in fact, talking to the Minister of Health in Colombia, who actually had the experience of trying to enforce in the Colombian parliament, where these syntaxes are needs to be validated. He failed to pass a sugar beverage taxes. The argument and the industry being really pushing back and saying, well, you're going to lose a lot of jobs, etc., etc. The second argument, so one argument was, unemployment, and then they were extremely powerful, in the media. The second was regresivity. And for the tobacco tax, which eventually managed to pass, a very significant one in terms of tax hikes, what it did is that the arguments were regressivity and the smuggling with Brazil, so on and so forth. But this is very, very, very common. Now, what's interesting is that there's two things when you look at a number of studies that have been done on that topic. One is that most studies assume that people are price responsive the same way, which is not entirely true, because obviously, and that's also, we know this because that's a way that you prevent smoking initiation for youth and adolescents who have less money, is that if you have less money, you're much more price responsive. But also, and you'll see that we are looking at consumption expenditures and so on across quintiles and cigarettes. But also, this is a very narrow view on what regressivity means. So I just gave you, the usual definition, but that's really a narrow focus on thinking about consumption expenditures. I mean, cigarette expenditures. That doesn't, look at, the distribution of those. That doesn't look at the health benefits, where those are concentrated, and then what might be, because you have a preventive intervention, what might be the financial or the elimination of financial burden for those who would then get lung cancer or heart disease because they've been smoking all their lives. So you could have prevented them from basically smoking and perhaps the likelihood of dying from those diseases by increasing taxes. One important thing that I didn't mention, is that tobacco is one of the biggest killers. It kills about 7 million people per year. There's about 60 million deaths per year in the world, and 50% of people who smoke will die prematurely of their addiction. So this is a very significant thing. And so when you have such a dose response, that could be significantly improving the situation. Now, so now let's take the example about, a specific example about how ECEA can actually, or can bring a new lens to the conversation. And let's look at China in particular. I won't go, there's more details in this paper, but just a few figures here. Well, first of all, there's, a very large percentage of the population smoking. Highly skewed toward men. I always say there are more people smoking in China. There are more people smoking in China than there are people in the United States. There's more than 300 million smokers. There's a relatively strong socioeconomic gradient. If you're poor, you'll smoke more. There's slightly different consumption of cigarettes versus socioeconomic status. Interestingly, I mean. Colleagues of mine and former colleagues of Peter's have studied that quite a lot. There's, in spite of very high insurance coverage, China health reform, the free schemes of insurance, I'll go quickly, skyrocketing to 98%, you still have very large out-of-pocket payments, whether it's for inpatient care, outpatient care, with actually quite some variations across provinces. I don't call it insurance, because if you have a $10,000 cost for lung cancer, if you pay $5,000, that is going to be very expensive for a low-income family in China. So that is quite significant. And then expectedly there is some variation in price elasticity of demand for tobacco consumption across quintiles. So let's see about what we did with ECEA here, and looking at basically the three kinds of things I mentioned, earlier. One on, the health benefits, then the financial risk protection, and then also looking at the specific incidence of the consumption expenditures. So, and we looked at a case of, a 50% tobacco price increase, among the whole population. The first thing that we find, and you'll see many of these graphs, you have basically the different income quintiles, poorest to richest, and then you have the death average. I mean, basic modeling, I'm not going to go into the detail, but following the current population over time, and then looking at a 70-year time frame, and look at what would be the reduction of mortality. I should say also in terms of epidemiological background, 50% of people who smoke will die prematurely. Now, if you quit smoking, you have benefits at all ages of your life. If you quit smoking before 40, you basically have a 95% reduction of your excess risk of mortality compared to non-smoker. That reduces, even if you're 60 and above, you still get about 20% reduction. So that's very significant. So that's how these are computed. And what we find here is that we find a poor gradient, more deaths averted among the poor than among the rich. And that is not very surprising. Why? Because there are more smokers and there are more price responsive among the poor. But again, opening the discussion of regressivity that we're actually poor in health here. Second thing is the financial risk protection, where what you have here is same population, poorest to richest, and then looking at out-of-pocket expenditures averted. Okay, relatively flat here, more or less related to the fact that in spite of having more smokers among the poorest quintiles, you actually have richer people seeking more care. That's a well-known thing. And so that's sort of mitigated here. Now, if you think about the financial risk protection, because poorest incomes have by definition less income, they actually get a much more significant financial risk protection benefits. Because again, spending $100 when you have $200 of income is not as impactful as if you have, say, $1 million of income and so on. So we're pro-poor on financial risk protection. So again, expanding, sort of revisiting other regressivity arguments. Now yet, if you look at consumption expenditures, so the net difference in the money you spend on cigarettes, okay, by socioeconomic group, you have these sort of flat, distribution compared to income. Now that becomes that the share, the net increase in cigarette expenditures is higher among the poor than the rich. Now what happens, we've done some additional modeling, is that if you actually increase substantially the price, more to like 70%, 80%, and you have a sufficiently strong gradient in price elasticity, you actually have, in net change, you have something that can be proportionate, arguably for very large price increase. What I mean by this is that it's not meant to be always regressive. Now, from a policy perspective, these very high, increases are not always taken forward. So in sum, what we find, and there's other studies that we've done, is generally not surprising because it depends on where the risk factors are concentrated. These are pro-poor on health gains. They're pro-poor on financial protection. Now, this is mitigated by the kinds of underlying context of health insurance you have in the country. We did a number of other studies on this, including one in Colombia. I mentioned this was in China. And in Colombia, actually, what happened is that the financial risk protection benefits are low. Why? Because we have a catastrophic fund that actually takes care of heart disease and lung cancers and so on. And so, that by design, it was already taking care of it. So that might be mitigated, obviously, by the level of insurance and, social protection we have in countries. And the last thing is that, as I just already commented, is that it may be pro-poor for certain levels of price increases. So in summary, the take-home message is that, it's a more nuanced version about, arguing that, only regressivity ensues with, increases in tobacco prices. Okay? So one more example and then maybe a few concluding slides. The other, so that was a very, a very specific example, which is that the ECA was actually addressing or bringing some new elements into a debate about, the regressivity of syntaxes. Now, more expected or more general use of this is obviously around like designing essential health benefits package, which is very much, what in some ways the end goal for, health technology assessment agencies or a massive use of, of cost effectiveness analysis. So basically, and what I'm going to do here is I have three kinds of things. One is a very simple example, so that you understand exactly what we do, which is about rotavirus vaccine. And then, how we can think about a package of vaccines, and then ultimately a package of interventions. Okay. So what we're basically doing, a very simple example, rotavirus vaccine that the government of India or Ethiopia would pay for. Okay. And the Ethiopian numbers are higher. That's because it's scaled to the population. Otherwise, the Indian numbers would be much bigger. So India in red, Ethiopia in pink, but the patterns are the same. And the first thing is looking at deaths averted, okay, for 1 million, birth cohort. Always the same: poor socioeconomic status, rich socioeconomic status. And what we find is that, and rotavirus diarrhea is actually has decreased thanks to scaling up of vaccines, but is a significant, cause of death for 95 children in many low-income countries, India, Ethiopia in particular. What we find is that, the vaccine would have larger health benefits among the poor than the rich, essentially driven by the fact that there's a higher burden of disease among the poor than the rich. So that's, one thing. Second is to think about the distribution of out-of-pocket payments averted. In other words, I roll out a vaccine, I prevent a child from having diarrhea, so I prevent the parents to have to pay for diarrhea bills. Okay, so that's how the prevention of financial implications. And what we find here is same thing, same countries, poorest to richest, and we have a increasing gradient, more out-of-pocket payments averted among the rich than the poor. This is, as I mentioned already, similar to China, similar to the China case, is that we know that it's related to higher utilization of health services and hence sort of opportunity to pay for medical bills among the rich than among the poor. And the third, you've heard that story already, is that now scaling back to income, we actually have higher financial protection among the poor than the rich. And that's because for those, even though there are fewer that are seeking care, in other words, the poorest, there's actually a higher financial protection because we have less purchasing power. Now, the way we can think about these things is that was just one illustration meant for, just conveying, the sort of underlying sort of approach that we're doing. Now we can do it for a whole bunch of vaccines. So this is a paper from a former graduate student who's now an assistant professor in Denmark, and where the same idea was to look at a package of vaccines. Specifically in that case, what would be the deaths averted, okay, in different quintiles. The poorest quintiles being the darker greens, okay, the richest being the orange colors. And then, similarly, for how many cases of medical impoverishment would be prevented by the rolling out of vaccines, all right? The poorest being here, the richest being there. And looking for about 10 vaccines, antigens, measles, Hep B, HPV, and then what would be the benefits in 41 low-middle income countries for the vaccinees or vaccinees around this period. Okay? And these turn to be what we call Gavi eligible countries, countries that receive subsidies to basically implement these vaccines. So you can see that with these kinds of things, what we can do is then think of bringing more ingredients in spite of course, having absolute numbers, right? Total number of deaths averted, total number of poverty cases, how these are distributed. So then what we might do is we might want to prioritize or sequence first, the vaccines that yield more equity benefits, whether it's in terms of health benefits or reducing health inequalities, and then same thing for the medical impoverishment piece. Okay. Now, the thing that we can basically do, there is no reason for us. I think it's interesting from a sort of sub-health domain. Obviously, in many countries there's an EPI program where they think about new vaccines. As many of you know, there's a discussion about old form of vaccines like the measles vaccine, new vaccines, rotavirus, HPV. How do you prioritize, and with which kind of money, whether it's domestic money or donor money, you should prioritize. Now, beyond probably delivery platforms like the EPI that I mentioned, which is relevant, what we can think of is how we can use this for thinking about all the interventions that the public sector could finance. So this is a paper here, and so what I'm trying to say here is that basically what we could think of is how we can use like this to think about revising a benefit package that's publicly financed, or in other words, trying to include like the identification of best buys in poverty reduction. So this is a paper that we did here, for instance, for 9 interventions that would be publicly financed in Ethiopia with, say, $100,000 spent, and then looking at the number of deaths averted. Okay, so the more on the right, the better. And looking also, so this is cost effectiveness. That's where we go all the time in cost effectiveness. How many deaths, how many DALIs do we avert, or how many qualities do we get per dollar spent? But adding the dimension, which is how many poverty cases or medical impoverishment relating to illness that we would prevent per dollar spent. We looked at 9 interventions. We wish we could have hundreds of interventions. Actually, I think we probably could do that easily in British Columbia with thousands of interventions, and also actually perhaps looking at pharmacare. In Ethiopia, we had much less data, and so the selection of interventions, arguably essentially biased toward maternal and child health, is a reflection of the data that we had available from demographic health surveys and other kinds of household surveys we could have data on, as well as studies on out-of-pocket payments. So, but what we can use that for is, and you see the interventions, I think you can see it, different vaccines for which we have a lot of information on, but also things like hypertension treatment or cesarean section, tuberculosis treatment, and so on. And the point here is that there are things we know already. We don't need to do a millionth cost-effectiveness study on measles vaccine. We know it's very cost-effective. And in fact, that's what we find. That's measles vaccine. It's very cost-effective. Now, what's interesting here is that we bring a new dimension, which now we can think about what is the best buy in terms of poverty reduction. And there might be things like NCDs, for instance, like picking on hypertension treatment, that maybe are less cost-effective on the x-axis than other things, certainly less than the measles vaccine, but yet are very cost-effective because the simple hypertensive drugs, cheap, can prevent very expensive heart attacks, and that might be things to consider in terms of for a government to think about. Well, in addition to think about reducing disease, I might want to reduce poverty related to disease, and there might be have a dimension over which I can make, resource allocation. So let me have a few concluding slides, and then I guess we'll open it for questions. Is that good on time?
Yeah.
Okay, excellent. Okay, so let's talk about perhaps a few uses of this, which will be a sort of rehearsing about how we talked about. So the first thing is, and how can we use this for pricing? Broadly speaking, and not surprisingly, there's two ways you can think about this. First of all, there's a priority setting exercise within the health sector, right? And by doing this is, really not rocket science. The first thing that we do is that, as you see, and this is an example of, that's actually the India and Ethiopia discussion, with basically per $1 million spent, how many deaths averted, how much financial risk protection you get, and basically disaggregated by socioeconomic status, one being the poorest. And by simply being explicit and estimating these distributions, what you're able to do, as you see here, so the more here, the better, the more on the right, the better, the higher, the better. What you can do is point to progressive prioritization, simply because you're explicit about it. By the way, here, I always hear, it's certainly true. In some instances, equity efficiency trade-off. But here, what's most perhaps equitable, so an allocation among the poorest socioeconomic group, turns out to be the most efficient because located closest to that right, hand corner. So one use is that if you're interested, if your social contract as a policymaker is to really prioritize certain segments of the population, in that particular case, the poorest socioeconomic groups, you have a way that you become explicit about what's your return on investment in both mortality reduction or health benefits as well as financial risk protection. So that's one use. Similarly, what you can do, and it's same thing as the previous picture, is really being explicit about, besides the distribution of those socioeconomic groups, being very explicit about financial risk protection. So what we've basically been doing, so imagine you have a certain budget per dollar spent, same graph, same thinking. What we've basically been doing in cost effectiveness analysis is trying to get really on the right hand side of it, is really get health benefits, more health benefits per dollar spent. We didn't really care about poverty reduction benefits or financial risk protection benefits, and so on. What I'm arguing is that we can perfectly also think about using the same sort of, which at the end it's about your social contract, enough thinking would be an objective function. You can think about adding another dimension and then start to consider interventions in terms of their return on, say, poverty reduction. Thinking, back about my first slide, thinking about health, then how health can contribute to basically the discussion in terms of poverty reduction. And we might find, also within the health sector, that there's actually things that, like the hypertension treatment, might not be so cost effective in terms of health benefits, but actually be quite cost effective in terms of a return on poverty reduction. And actually, just to push it forward, and we're talking with Craig, in many ways I'm convinced we have health systems because of financial risk protection. If you look, for instance, in Western Europe, after the Second World War, there was really, obviously, disastrous, wars and so on, and perhaps it was specific, it was the time for that, but really in the constitution of a health system, an idea of welfare. If you read the statutes of the NHS, it's explicitly mentioned that this is something to address the money words. So in other words, think about, for instance, pharmacare, the way you might want to think about pharmacare, or you might want to think about the British Columbia health system is, had there not been this great, publicly financed system, what would have been the financial consequences for families? Actually, I think it's even more important in times of austerity. In fact, that might be a question that the United Kingdom might have to address very soon. And these questions about how you think about health in the context of social protection are very important. And I think that's one thing we should be really explicit in the way we think about health technology assessment. And then to end with, I think that becomes particularly important when we think about priority setting beyond the health sector. Because obviously, number one, the decision maker, sadly, is not the Minister of Health. The decision maker is the President, the Prime Minister, or the Minister of Finance. And he needs to have metrics that, like growth or poverty reduction, that speak more to his language so that he can respond to, so he can make intersectoral comparison. And I guess my last thought on this is that it's also from a sort of planning purpose, health is just one way of redistributing resources in society with taxpayer money. And often, the social protection, or the countries that have better social protection programs are countries where things are more integrated. Thank you.
Thank you so much. That was really great. Provocative, stimulating, and challenging to think about it in the global context, but also how it can relate to, these topics relate to some of our worlds in healthcare and social determinants in Canada as well. What I would like to do is ask Emily to put up the slide on the Slido, so that's going to start to allow people to enter their questions. And I'm going to ask Larry and Wei to come up and take a spot on the panel here. This actually gives me an opportunity to thank the amazing Alex and Simona for all their help and putting this on. Not just the moving tables, but organizing everything behind the scenes, so thank you. And I will introduce Larry Lind. Larry's Associate Director of Research in the Faculty of Pharmaceutical Sciences. Great to have you here, Larry. Thanks for coming over. Also an adjunct in our school, so it's great to have you here, Larry. And Wei Zhang is an assistant professor in SPPH and health economist. And I'm going to turn the floor first over to Larry and then Wei to give a few overarching comments, thoughts on what they've heard from Stefan, and then we're going to open up to a moderated session which will include your comments. So if you, anytime here on in, want to go to slido.com, enter the event code, maybe just take it out of the slideshow mode, and then that will just stay up on the screen. And you can start typing in questions, and we'll moderate that as we go. So, Larry, if you would like to go first with a few thoughts, hand it over to you.
Okay, thanks, Greg. And thanks for the invitation. And I said to Greg, I wasn't quite sure why he actually asked me to be on the panel today, other than there was global in the title. And I do work in Cambodia and Rwanda, and so I've had some thoughts about that. Thanks, Stefan, for a great presentation. And we always are talking about trying to value non-health benefits, and how do we do that, and how far do we go, and where do we stop. So this really got me thinking about valuing those non-health benefits beyond cost-effectiveness analysis. And I'm going to just talk very quickly about the project we did in Cambodia, where I wish I'd had this methodology about 3 years ago when we were trying to do that, and how it...
One sec, we have to do a quick change on the... Hold that.
Okay. That's not easy these days, Greg.
Speaking of healthy aging.
Okay, let's try that. Is that right? Okay. So, this was a project where I got involved with a group here from Land and Food Systems, and we did a nutrition intervention. It was rather novel. I knew nothing about nutrition, but I was brought in to do the evaluation. So we did a 3-arm cluster randomized controlled trial on a dietary intervention increase dietary diversity and food security to increase the health. And we went into these small subsistence villages where they, of course, had no power and no water, and they were gardening. So what we did in 1,000 households, where we randomized them to nothing, or to a home garden, or to a home garden in a fish pond. So we went in and we dug 300 fish ponds and built 600 home gardens, and then we evaluated it for dietary diversity and food security. And it was successful, and so we got scale-up money from the Canadian government to go in and do 6,000 households. But what we learned was it was more than just the dietary diversity and food security that was influencing anemia and zinc and some other sort of health level outcomes. But one of the biggest benefits, and you talked about the financial risk protection, and looking at that as not having the expenditures on health, what was really fascinating about this project was we were able to help them generate revenue from what they were growing in their fish ponds and their gardens. So not only were they eating the food, they were generating revenue, and they were becoming more affluent to the point that the mothers or the women in the household didn't have to travel anymore to Vietnam to work in the factories. They were staying home with their families. We talked to one fellow who his life changed because he was able to buy a bike and a trailer, which meant he was able to get his produce to the market and sell his produce, and then come home and buy no more food and buy clothes for their kids. So just to have that way to evaluate that financial risk protection, I think, would have been really helpful. We did a cost-benefit analysis that's currently under review. It's not perfect by any stretch because of the environment that we were working in, but I would have found that a really kind of a valuable application to where we might be able to measure some of those non-related health benefits. Now, the other thought I had was a little closer to home, and the other area, my primary research area, is around rare diseases. And I'd be interested in your thoughts, Stefan, as I sit on the advisory committee to the Ministry of Health, and we provide advice on spending on drugs that range anywhere from $250,000 to $3 million per year per patient, and we're just waiting for the next one to come. It's going to be our new highest. It's going to be $4.4 million per year per patient. So I was thinking about financial risk protection, because there's no policy that's going to offer them financial risk protection other than full payment, because they don't pay. They either don't get treated, so therefore there's no economic hit to them because they just can't pay. But I was interested in your paper when, and in this environment we really don't use cost effectiveness analysis because they're not cost effective. These are value laden decisions. So I was interested in your paper where you were talking about being able to integrate the other opportunity costs of funding programs and not funding other programs. And so within our committee right now, we're having discussions about, within that finite budget, it is within the pharmacare budget. We spend about $30 million on 75 patients, and we're projected to spend about $75 million on 250 patients over the next 3 to 4 years. So that's going to work out to be about 6 to 7% of our provincial pharmacare budget on about 250 patients. And the ministry has actually put a table together about 6 or 7 other programs that run around the same amount that we're spending now, somewhere between $10 and $30 million, but somewhere between 10,000 and 40,000 beneficiaries within those programs for the same amount we're spending. At the last meeting, we were talking about really kind of hitting our ceiling and maybe not funding a given drug in this particular budget cycle because there's no money left. And you talked about being able to integrate some of those opportunity costs of not funding other programs through a choice of funding a given program, and I'd be interested in your comments as to how you've done that, or how you might do that, and how you might choose what to look at in terms of the opportunity cost and be able to balance those trade-offs, because that's very real in pharmacare right now in British Columbia, and I think these are the decisions that we're going to have to make. So with that, I think I'll just stop with those comments.
That's fantastic. Do you want to give a quick response to those, then we'll turn
Thank
over to Wayne?
you for an easy question. No, I think this is very important.
I think, so in quick, I don't think the sort of threshold of cost effectiveness where you have, if you take the sort of the York NICE, it's about the public health budget, which is a very strict definition of the healthcare budget. So I think that the way, and we're trying to look at this, which is what is the willingness to pay, it's slightly different. On the poverty case study, I think maybe the right way to think, or one possibility to think about these things is to think more about social protection budget. And health is just part of a bigger redistribution idea, and that in some ways, one analyst could look at that. I'm not sure that would necessarily bring a good answer for your specific research question as well. You have, rather than thinking about the limited public health budget, you think about what are social protection budgets, and then maybe that's like a better indication about what you do there, how that would displace some investments. That's one idea. This is certainly a complex one. But the other thing is, one could be very technical in many of those discussions, but also there's ethical priorities. Yeah, and I think that these are things that are beyond what a mathematician or an economist perhaps can solve with some analysis. But these analyses could be helpful.
First, thank you for the great presentation. I don't have a lot of research on in terms of global health, but I did some economic evaluation in context of developed countries like Canada. So as Stefan mentioned, in terms of cost effectiveness analysis, the perspective mostly used is the healthcare perspective. But actually the work I'm doing is one of my research interested area is measure the impact of health problems on work productivity of patients and of their caregivers. So most likely this is not for under healthcare perspective because it's work productivity, is job loss or in terms of their income losses fall under societal perspective, but not healthcare sector perspective. But it's good to ask Stefan one kind of comment is, if we take a societal perspective, so all your out-of-pocket expenditure, usually we consider as a part of cost component. But your presentation is, you regard it as an effectiveness measure, which actually is a kind of two ways to deal with out-of-pocket health expenditure especially. So I just wanted to know how do you compare these two different methods to deal with out-of-pocket expenditure. And then my second comment is, you mentioned actually from your China example, so you said the inequity is already a little bit mitigated by the health insurance design. So basically, back to you is, you think it should be universal health coverage, or you should, for this case, whether you should cover people with low income more than, is like go back to high level, like how to design healthcare insurance, whether that can help address this inequity problem. My third comment, sorry, is about the actually syntax in terms of the smoking tax. Actually, I'm not sure your study focused on all the impact on the existing smoker. Have you looked at how the tax impact of preventing younger generation start smoking, whether that impact also have such like inequity across different income percentile?
Yeah, three questions very much on target. So on the very good point about the societal perspective versus the health sector perspective. So clearly what we're doing is we're taking a health sector perspective. And then, so in the societal perspective and cost effectiveness, what you have is that you have both the costs from the provider as well as the out-of-pocket costs. But they're often actually, not included. For those who do cost effectiveness analysis, there was a second panel, US panel on cost effectiveness guidelines, and what they eventually recommending is that to do potentially both. But in practice, actually, I went to, before coming here in Portland, I was at the medical decision-making meeting, and there was a presentation from Tufts, where they have a cost-effectiveness registry that, in practice, and we find that in the literature, very few people are actually doing the societal perspective. Why? For two reasons, in my view. Number one is that, well, our audience, not always, but is, the government, and the government wants to know what it's buying. Second, I always find, and that's my view on these things, the societal perspective very confusing. Because if S is equal to A plus B, and we produce S, or C, the cost, we don't know whether it's coming from A or B. Because it's basically, we lump sum both the outer pocket. And so my view on this is that, so there's, in practice, the audience is the policymaker. Then, in sort of the analyst perspective, this is confusing. And third, I really think that we need to think about investing in health in terms of social protection. So then I'm thinking, well, we should think about it in terms of how much financial risk protection we buy. And I guess related to what you're saying, I think that, to the work you're conducting, which is very interesting about the caregiver aspect and so on, I think this is one more argument to think about extending the sort of, what we mean by out-of-pocket and put that in the effectiveness. Because that's what a government should do. The government should, people could contest me about this, but should think about how you reduce inequalities. And health is just one way of thinking, or one instrument to provide it. On the tobacco, very good questions. You'll tell me if I missed one of them. Yes, so we have, and I went to that quickly because I really wanted to emphasize more on the big picture stuff, but more is in the paper. Yes, so the way it is, it's a current population, and then what we have is that we have both the people who are smoking and the people who would smoke. So basically, population from 0 to basically 80 and so on, and then the 0 to 15 don't smoke, but they would foresee the smoking rates of the populations ahead of them. And we had actually information by both socioeconomic status and age groups, so that we can, with some reasonable assumptions, do that forecast. And you had a third question.
Insurance design.
Oh, excellent, yeah, absolutely. So very good. Thank you for bringing that question. Yes, you're absolutely right. So, in fact, we saw, as I mentioned, we did, similar, it was very interesting. We worked with the World Bank, who liked this kind of analysis. Also, they had, an agenda of enforcing tobacco taxes, so that was helpful to them. And then, so the situation in Colombia was vastly different than in China. Because actually, Colombians, and the minister was very happy. He was saying, well, this is a testimony that we have a redistributive health system. Because, basically, there's no financial protection benefits. Now, the thing is that a position, now you have a second sub-question within that, which is then, well, why don't you increase health insurance? Or the share of out-of-pocket payments, which, by the way, is not, again, so different from the pharmacare story, and so on. Now, I won't answer directly your question, but I really think that there's, which makes sense. The way we see the way people see financial risk protection is essentially for health insurance. But I really think people undervalue the financial risk protection benefits of public health interventions or preventive interventions. The thing we have in our mind is we want to prevent rare, expensive bills, a shock. And that's, the whole economics literature is about acute shocks, catastrophic spending, and so on. But actually, there's, provided that it's not too expensive, I think there's a lot of things that you could do in terms of prevention. You don't smoke, you don't drink too much, you don't get run over by a truck, you don't breathe bad air. These are things that can prevent. Now, you don't act on the financing mechanism, you act on the disease. And I think that this is one thing that we should think more of, is the cost effectiveness in terms of financial protection of preventive interventions and emergency health insurance. But thank you for the excellent questions.
Fantastic, thanks Larry, and thanks Wei. I'm going to throw in one myself before moving to some of the comments that are coming in on Slido. I know a little bit about priority setting, particularly in the context of healthcare in developed countries more than developing countries. And my question, Stefan, is around why financial risk protection, health gain, and household expenditure as the key criteria that you're including. In our context in Canadian healthcare, we often have 10 to 12 key criteria which would include health gain. It almost certainly wouldn't include the other two, although appreciating there's some debate over that in pharmacare where we don't really have universal comprehensive coverage. But you could get into issues around recruitment, issues around workplace safety, issues around access, different types of equity, all important criteria in the resource allocation game. Why did you bring to the fore these three criteria?
Yeah, no, excellent. I think, I would have three quick answers. One is, I think, things is to be decided when people make decisions, or again, I don't want to make it philosophical, but more social contracts. What are your values? Obviously, these are one set of things and people are others. So that could be expanded. Now, the two main motivations is, number one, I'm relatively young, but even in the last 10 years, I've been working on that topic of cost effectiveness systematically. I have footnotes, or sometimes at best, a discussion point in the discussion section that, this is good for equity. But there's no explicit consideration. So that would be one. The second, I think, is really the long line of scholarly work. Peter was a contributor to this. That I think two examples that come to mind are the work, the sort of Chris Murray, William Frank thinking, about health system performance, where they talk about, and these are the same, criteria. The work of Peter, Bill Shaw, Michael Reich, Mark Roberts, about getting health reform right, which, long story short, there's a consensus, there's sort of consensus of scholars, international agencies, that when you think about performance of health systems, you want to care about level and distribution of health, level and distribution of financial protection, and also some sort of citizen satisfaction. Now the latter is something clearly we have not included. So that's, I would say the two things I mentioned are the sort of things that brought us to. And then now you can include more things like your work on ECEA, and I think there's value for the process, but the longer you add on the list, the harder it is to get information.
Larry, do you want to comment on that with respect to DCEs and how you could actually capture?
Well, I think, to that point, and I had another point written down here, and maybe you can comment, Stefan, is we do these free choice experiments, or whether it's MCDA, we can come up with a whole catalog of potential factors that might influence a decision and priority setting. How do you respond to the, we've all had to address the modeling pundits that say, well, now you're just trying to add on more non-health benefits to make your technologies look better so that you can get them funded. and that's what we hear, right? Particularly those who, first of all, they don't like the models because it's a black box. Yeah. Second of all, I'm being devil's advocate here, but we're just trying to add on more benefits to a different technology, and then they're all different, and we have to compare across technologies to decide what we're going to fund. Have you had to address that issue? Yeah,
no, sure. It's a very good question. I think simplicity is always, or at least simplicity and exposition is always quite useful. One thing that we have done, and even though we pursue some analytical work about aggregation, is to provide dashboards, so that you basically don't have to weigh things differently, or we let the decision makers to make the weight. So that's one thing. And even things like DALIs are very hard, and it's the aggregation of things very hard for policymakers. So we're not doing so much DALI things here. One, and then trying to make things, dashboard, people can do that. Second question, I think the way is, I absolutely agree. You have it's always the same. You have a TV guy, is only going to do the TB, and suddenly the numbers are big. Then you have malaria. I think the way to go is just you be consistent and you do the whole thing. Like you just have a systematic thing, and then you compare. And often what we find is that that's fine. That's how academia works. And these groups they focus on their own thing, and often but I think if you're consistent and you apply the same thing, I think that's one way, but probably others to address it.
Okay, let's thanks Stefan and Larry for those further thoughts. So let's go to a couple of the questions on Slido.
Craig, could I just ask
Yeah.
you to just let people know that not only can they ask a question on Slido, but they can indicate their preference for certain questions.
Great. So just a note from the audience here that you can not only ask a question on Slido, but you can also indicate your preference for the questions that are being asked. So if you want to push something to the top of the list, you can do that. And so I'm going to read off one question, which has just come in, around, I'll just read it. What have you learned about the challenges of factoring in and estimating downstream poverty effects in countries with mixed health insurance systems?
That was not my preference. I think I answered your question. I haven't done it. Well, actually, we've done some studies in South Africa where what we found is that, because I'm not a specialist in the South African health system, but there's, really different segments of the population have access to different things. And in fact, actually, one result, which is very much like, the question that we had. I think that in many ways, many of the studies are, to be contextualized because it depends on the health insurance system. So the South African one, what you find is that basically, it's benefiting a lot from the middle class. Why? Because there's a proper health system that basically if you increase sugar and beverage taxes, and so the poorest segments of the population will be really taken care of by the publicly financed system for the poor. But I cannot, I'm not, I don't have so much experience about in the context of mixed systems to comment on. Except the fact that obviously the sort of underlying background has eventually ways question responding to the kinds of results that you can find.
Great. Another question then that has jumped to the top of our list. Feeling the excitement here. Is there any evidence that prioritizing a pro-poor approach has unintended health cost consequences for other income groups?
You don't have to answer.
I just need time to think
I
of.
think it's for way.
I just need time to think of.
It's a complex question.
Yeah, it's depends on, right? No, I don't know actually because we haven't. I think at least in Canada we don't have yet. There's no observation for both. Like it's opportunity cost, as like Larry mentioned. Like if you have one policy for poor, it's usually we only observe one group rather than what's potential impact on the other groups. That's also kind of challenging for a lot of research. It's not only regarding income, equity issue is not really only related to income. This is one of the characteristics to try to describe equity. There are people mention the age or gender and some people with under access served groups. So I feel like a lot of study focus on one group rather than compare the impact of any kind of intervention impact across the whole population. So that's my thought.
And maybe just another comment, I don't think it's unique to the low-income population. If you think here in Canada, we have all sorts of special programs targeted at special populations. And we've made a value judgment about what special populations we want to fund, whether it's HIV or oncology or cystic fibrosis or whoever. And we don't know what the counterfactual is, that what would happen if we'd have funded something else other than those programs. So I don't think those equity issues just hold to income or social status. They go across. And now we're having this discussion about people who, just out of bad luck, have rare diseases that require expensive drugs. We're having those discussions.
Thanks, Wayne. Larry. Question for any of the three of you, I guess. How do you define values for price elasticity across income quintiles? And I think for Stefan, are these included in your models? Stefan, start?
Yeah, sure. Yeah, what you do is that, so the second question, the second part of the question, yes, they're included and they're very important because that's part of the universe differential price responsiveness. And then the way you do that is, you have household surveys, and then you have different price hikes, and then you look at the response and household surveys that include consumption, expenditures, and then you look at when the hikes happen, and then you looked, and because you have data by different socioeconomic groups, you're able to look at the reduction and then able to estimate the price elasticity parameter.
I think, Larry, I think you'll have some comments on this one, but open to any of you. Is a health system focus the best way of truly understanding financial risk protection when social determinants of health may have larger effects?
Somebody read my mind because I actually had that question. I didn't. For Stefan, I don't have an answer to that, but we often talk about the societal value of investing in social programs or education or childcare relative to healthcare. So, one of my questions was, being able to do this across sectors beyond the healthcare system to look at what some of those non-health benefits might be and be able to compare. So I just asked the same question again that somebody else asked.
No, I'm just adding on that. So in terms of that, is compare across different sectors, then we go back to societal perspective. But actually, I think a group of researchers in Harvard University is Dr. Lisa Robeson.
Sure.
Yeah, so she's leading a kind of, we call cost-benefit analysis, but they call benefit cost analysis reference case for WHO. So that really try to, the difference is for the benefit, they try to assign dollar value for the effectiveness here, like assign value for the death averted, for example, or the value for the improvement in terms of quality adjusted life years. So that will increase the comparability across different sectors. If a policy have a transportation or some policy focus on education, so that's increased the comparability. But I can go back to your, you probably can go back to your method with the strengths and limitations in terms of the sector comparison.
Yeah, no, I think that's right. One thing is if you put a dollar value on, there's obviously huge ethical implications by doing that. Then you're able to have a comparator. You're able to compare health investments with other sector investments. I think a question, or the way I was reading the question was slightly different, which in my slide, it's true, I have a sentence which is health system focus. So just two comments on that. One is that it was meant more to think, in my view, in cost effectiveness. We're really focused on technical intelligence, like new drug, and partly because the pioneers on that work in terms of HTA have been doing that in the UK in particular. Whereas I really think that to be debated, it's so relevant, especially I think in the context context of many things are outside the health sector. But anyhow, my point was that in nominal income country setting, I think we need to think more about platforms, because really, for instance, you have certain platforms that are related to the kinds of health workers you have. You have community health workers who do a lot of primary care. You have also a lack of human resources, and the way the managers and policymakers are organizing and thinking as well, how do I deliver certain things at different levels of health? The same is actually true for, I'm sure, we're talking about drugs, we've been talking about drugs for a little while. Now, the other thing is, I fully agree with that. Now, it's the way, I meant to use that word in the slide, to think more about how we need to broaden the conversation from technical intervention. Now, the other thing which you're bringing, I think to me is absolutely essential, which is, most of the variations in health outcomes are outside what is the Ministry of Health sector. And I think that, there are things like, again, if you smoke, if you, drink too much, if you get run over by a truck, if you breathe by bad air, if you eat unhealthy, these are things that are, basically having a lot of impact. And I think these are things that, kill, disable a lot of people. Technically speaking, they're not Minister of Health responsibility. And I think, we understand more and more the Minister of Health as a guy who runs a hospital. And I understand it's harder to talk to multiple ministers, the transport guy, or many different people that act upon these things. But I think that one way to think more about, priority setting is to think more about social determinants, public health policies, and how we maybe talk to multiple stakeholders and we bring in, the Minister of Health in the discussion. And we shouldn't think if in a country, there's people dying of something, we shouldn't think, but isn't my responsibility to do that? We should act upon it. And it is not, necessarily easy to, and I think partly it's because these are things that are harder to measure. They're not technically RCT kind of things. And then also it's like it's a much more coordinated thing. I don't have much, insight about this, but my observation is that countries where things are more integrated, tend to work better. So it's good.
And in fact, on that last point, one of the things I get into in my priority setting class, which for those of you who are students is SPPH 547, starts January 1st.
January 1st?
January 2nd. One thing that we get into in a great level of detail is that challenge of silos. And we see it here in Canada all the time, where the ministry is responsible for this, the Ministry of Health is responsible for this, but what about education? What about social services? What about other aspects? And when you take a priority setting frame, you're almost always just doing it at a single ministry level. So it becomes very challenging, actually, to take that broader view. So one other question for you, Stefan, is in the syntax example, your measure is based on the proportion of low-income strata that does manage to stop buying tobacco. What about those that cannot stop?
So it's actually, the measure is actually including both. So it's a population level, I should have, again, I read a bit quickly. So it includes both the people who quit and the people who continue smoking.
I'm going to give a nod to Christina, who I have no doubt, because of your thesis proposal, the question you're wanting to ask is around uncertainty. So, Stefan, how does extended cost-effectiveness analysis capture uncertainty?
Put you beside Craig.
So the way, the same methods, so hi Christina. It's a very good thesis topic. So the same methods, I would say, by the way, a lot of this builds on cost-effectiveness analysis. It doesn't mean to replace cost-effectiveness analysis. It really builds on, so it means that the methods you use in cost-effectiveness analysis, which is, ideally you have a prior uncertainty around the inputs you have could, work the same way. And in some ways, using Monte Carlo simulations, having a set of input parameters with uncertainty that you vary could very well work the same. Except, of course, what you have is that you have additional layers of uncertainty. Because just one thing is that you have, different quintiles, so you have 5 more sort of inputs, if you will. But the same readily applies.
Wait, do you have any comments on that too?
I feel like there's a common technique trying to address some uncertainty for like a traditional cost-effective analysis can be applied in the same method.
Studies in Canada have shown relatively high out-of-pocket spending on prescription drugs. What might be the implication for providing government drug coverage of extended cost-effectiveness analysis? Wayne and Marianne look at me with blank stares. Stefan's excited.
I think you should answer that because I think that's the study you're going to need, right?
Well, I'm open to it.
You sure you don't want to take that?
You go for it.
I don't know. I think one has to. What I think is a great opportunity to do something meaningful here in DC. Is I think one should look at the list of drugs, and then look at what are the financial implications for different patient groups who have different income, and maybe make a call about, some of these should be delivered for free for some populations or with a certain components. But it's hard to tell without really, and I just learned about pharmacare this weekend, so it's also more hard to have a long-term, get a chance to do more. But I think it would be a valuable thing to look at the drug lists and do the analysis and then propose something, and then who knows, maybe the government will take it or leave it.
Okay, last question. There are ways to translate health gains into monetary values. Are there ways to translate poverty averted or financial protection into monetary value?
Maybe I give some background. So quite often in the traditional cost-effectiveness analysis, we're using quality-adjusted life years. There's one way we call net benefit. So we assign like a cost-effectiveness threshold, like when it's to pay per quality gain, for example, like $50,000 something for one quality gain. So we can transfer that to the benefit part. So then the question is like whether, for your case, like number of poverty averted, whether you can convert it into monetary value or something similar.
Yeah, no, absolutely. So 2 ways. One is that initially, actually, the first paper we developed, we used a risk premium approach with a utility function in the same kind of way that people, think about, insurance using, basically estimating basically with basic insurance theory the risk premium. That turned out it's nice and it returns a monetary value. Now, that kind of framework is not very easy to grasp with. We talked about transparency, easiness with policymakers, who in particular are using for a vast number of years the financial risk protection metrics of catastrophic health expenditures, poverty cases, which I'm not going to detail them, but there are a number of issues which the former method that I mentioned doesn't. But the former method, doesn't have, in short, much simplicity, and it's not easy to convey. Hence, we moved away, and also because there's these metrics that are already estimated. Now, Waze is absolutely right. In fact, I'm a postdoctoral fellow now currently working on that. The same way that you value, quality, or you say, in the UK, NICE is funding things that are below £30,000 per quality. What we're thinking about is how can we, think about the value of the poverty case severity. In other words, What is the threshold? Is it 10,000? I have no clue. $10,000 per poverty case, for a case of poverty. Underneath you bind, and then of course the question becomes across several dimensions. And actually, which gets back actually at your point and the way we're trying to do it. It's not easy. It's to think about not the health budget but the social protection. So to be consistent with cost effectiveness.
Great. It just is left for me then to thank you, Wei, thank you, Larry, thank you, Stefan, for a wonderful presentation, great discussion. Thank you to those in the audience for firing up some questions and helping us with this discussion. It's been a stimulating hour and a half, and again, thank you, and all the best.
Thank you.